morning, everyone. I'm very impressed with the people who got up this early. I'm like, really? People get up this early? But I was telling Sandy and Catherine this morning, you all are my people. Like the first ONS Congress, I'm like, this is where I belong. So very privileged to be here, and we're discussing United for Better Myelofibrosis Care, nurse and patient teamwork, and we know it's always teamwork, for personalized delivery of JAK inhibitor standards and emerging therapeutics. I'm Sarah, and then Catherine is right beside me, and Sandy Curtin. And we really want to thank Peerview and Haltree Foundation for Myelofibrosis for providing this session, and GSK and Insight Corporation also for providing the educational grants for this symposium. We're very grateful for that. If you haven't already, please go ahead and complete that pre-event survey so we know where you stand as far as your knowledge base about myelofibrosis and how you take care of patients. And throughout the presentation, we're going to have more polling questions, and so the more times you answer, the better your chances are of getting some cash in your pocket. And then for people that's for the people in the room. Sorry, the people outside of the room, that's not an option for you, so you get rewarded for getting up early. And there's a QR code following the slides that you'll be able to respond to the polls and also ask us questions. And then for the virtual learners, if you can still please respond to the polls, that helps us evaluate whether we were effective in presenting this material or we need to work on it a little bit. So this is how you participate and win a $50 gift card. So if you scan this QR code that's on your table, and you have your pre-event survey, and then answer the polling questions as we go through the presentation. And then at the end, there's the opportunity to ask us questions, and we'll be going through those. So there we go. And then visit us at peerview.com/MF26, and you will have access to the slides and practice aids that you can use with your patients and go back for your reference. And this is what we're going to learn today: nurses lead education, outreach to patients with MF on their symptom burden, which is great in this disease state because there's a lot of inflammation associated with the disease, the risk factors, and the treatment role on JAK inhibitors. And the second bullet there is that these can be used pre-transplant to reduce symptom burden, but you have to plan carefully. And MF-associated anemia is really a challenging cytopenia to treat because our current therapies, a couple of them, really can decrease that anemia further, but help greatly with reducing the size of the spleen and improving symptoms. So trying to balance those out and know what the appropriate dose is for patients is important. And delivering effective JAK inhibitor therapy, dosing paired with response, symptom and safety monitoring. So that's a job that nurses do very well, symptom monitoring and seeing how patients are doing on their therapy, and that leads to optimal delivery of care to patients with myelofibrosis. And so this is me. I'm a nurse practitioner and researcher at Moffitt Cancer Center in Tampa, Florida, which is hot and humid like it is here. And I love taking care of patients and doing research. And so this is a definition of myelofibrosis. Myelo refers to the bone marrow. And then fibrosis is really scarring. So on the left, you see a normal reticulin stain that is done on the bone marrow biopsy. And then on the right is the stain showing a person who has an increased fibrosis on that reticulin stain. And what you see in there are a lot of those fibers in there. And when you have a lot of fibrosis in the marrow, that prevents that marrow space from making the cells that you see, the white blood cells, the red blood cells, and the platelets that are circulating. So you can see cytopenic myelofibrosis. And sometimes Okay, I'll stop. So this is the first polling questions. Again, the more times you respond, the better your chances are for earning some, or for getting that $50 gift card. In your current practice, which MF-related symptoms most currently drive patients to seek additional support from the care team? And there's no one right question or right answer. All of these are symptoms we see, so which one really drives patients to seek support?
Will this come up after you completed the...
It should allow you to answer the questions. Right, yes, I agree. Fatigue is sometimes what drives the patient to go to their doctor. But you can see patients have a lot of symptoms. So this is a rare disorder. When you look at patients with myelofibrosis, they probably don't know many other patients who have it unless they meet up with someone in the waiting room that's scheduled to see you, me in clinic, or one of our MPN doctors, the myeloproliferative neoplasms. 13 to 18,000 people living with it in the United States. This is a disease of elderly patients. I'm almost falling into that category now, 65 to 69 years. It's rare before the age of 50, but as you've probably seen in the news, younger and younger patients are getting diseases that we typically see in older patients. So you have normochromic normocytic anemia. You can have increased or decreased platelets and increased or decreased white blood cells. So initially, when I started taking care of these patients, it was hard to pick out who had myelofibrosis. So you really have to do a bone marrow biopsy to diagnose them, because a lot of people have anemia and can have increased or decreased white blood cell count or platelets. They do have a leukoerythroblastic blood film, so when you look at that differential, you can see teardrop poikilocytes. One thing that separates these patients is they can have massive spleens, and in the beginning of the disease, it might not be that bad, but as the disease progresses, their spleen really starts to grow, and that's one of the keys that a patient has progression of their myelofibrosis, and you'll usually see changes in their blood counts as well. And for patients who have polycythemia vera or ET, essential thrombocythemia, as their disease changes into a more fibrotic state over time, one of the signs that may be occurring is that spleen starts to grow and the blood counts start to change from being overproduction of red blood cells and platelets to having to reduce the dose of the drugs that have been used to treat their disease. So you have post-PV and post-ET myelofibrosis. They're at increased risk for thrombosis or hemorrhage, and again, the fibrosis in the marrow. If you're not, we don't do bone marrow biopsies every day. So as a nurse, if the patient starts losing weight, fills up quickly when they're eating, that would be a good time to assess their spleen, and then that might lead to a bone marrow biopsy. And these patients can progress to acute myeloid leukemia, and it's a 10 to 20% over a 10-year period. So this is the spleen of a patient that I took care of for many years who had polycythemia vera, that then progressed to a myelofibrotic state. We did take her spleen out, but then she rapidly progressed with liver failure. So that's one of the reasons that we try to reduce the spleen other ways, is because you can have hepatosplenomegaly, and when you take the spleen out, they can rapidly progress to more of a cirrhotic phase, and ascites and portal hypertension and all the things that go along with that. And then the leukoerythroblastosis, I don't know if you can see that CBC with the differential for a patient with myelofibrosis. I can't see it well, but you probably are. So if you're trying to pick out a person with MF, this is what you would see. And one of the signs of the extramedullary, so making your blood cells outside of the bone marrow, Is the spleen growing? Sometimes people even get pockets of like what looks like a bone marrow biopsy outside of the bone marrow, like little growths along the spine. I've seen that. So very weird disease. So recognizing the symptom burden is very important, and how you diagnose this. This is really what this is telling you. So myelofibrosis symptoms on the left, and then the bone marrow, what's essential for diagnosis. The fibrosis we pick up on a reticulin stain and a collagen evaluation. They do have atypical megakaryocytes, which is a huge word, and that patients think you're speaking a different language. And those are what become platelets when they become grown up. So they do have atypical looking megakaryocytes that are clustered and hypochromatic. The molecular drivers, that's really where the science is going. JAK2, CALR, and MIPL are the three that we check for. And the high-risk mutations for a person who's healthy that might make you want to send them for a transplant evaluation are ASXL1, SRSF2, and we have a couple of others of those. And then we talked about that last bullet. And then looking at risk stratification, instead of having the TNM, where you stage patients, we use different staging scores. So we have the DIPS, the IPS, the MIPS, and the CHIPS. So there's a lot of like ways that you can look at these and score your patients. If you have a patient in front of you. For clinical trial enrollment, we typically use the DIPS. And then for secondary and post-polycythemia vera or post-ET myelofibrosis, we use the MySEC-PM. And then you can see age greater than 65, hemoglobin less than 10, a high white blood cell count, blasts in the peripheral blood greater than or equal to 1%, and then symptoms is a very essential part of that diagnostic or staging systems, as we call them, and then their need for transfusions. So I try to keep track of how many transfusions a person's had over time, and then also, which is really another feature that's really important, is the frequency of transfusions. How many transfusions and how frequently they're getting them. And then this is how we evaluate symptoms. So you can see there it goes from no problems to worst imaginable problem with that, as bad as it can be, or absent. And then fatigue, early satiety, all those initial questions we were asking for. And then fatigue is separated out because we know that's a real big problem for each patient. And then you add those up. So 0 to 10, and the worst possible symptom score is 100. And some places integrate this into EPIC, electronic health records, so that you can track this over time, since we don't do bone marrow biopsies every day. And you can see if the therapy that you start them on improves their symptoms or their symptoms worsen, as a way of evaluating response to therapy. And then these are the FDA-approved agents for treating patients with myelofibrosis. You can see their molecular targets. And for all of them, it has to be intermediate or high-risk disease. And then these are two, you'll see Health Tree Foundation for Myelofibrosis. This is the company that helped sponsor this event. And so it's really a great place for patients to meet other patients and really learn more about their disease. And I don't know if you were watching some of the commercials in the beginning, but they also have a way of helping other centers see their records and monitor patients. And then they do have an advisory board that is made up of nurses. I do help with this nurse advisory board, so it's a really great foundation to refer your patients to. So now I'll turn it over to Catherine, where we'll go through a case study and some more details. Thank you.
Thank you so much, Sarah. Okay, good morning. My name is Catherine Johnson. I'm an advanced practice provider manager and a practicing nurse practitioner for patients who are participating in clinical trials with myeloid malignancies at the Icahn School of Medicine at Mount Sinai in New York. It's a tremendous pleasure for me to be here with all of you, and then also with these two colleagues who I think so fondly of. I've learned so much from them over the years, so I think you're in for a good learning session this morning. We're going to talk about starting the journey with JAK inhibitors, including some nurse strategies for early interventions and consistent controls, using a case study to sort of guide us through what we might do in one of these scenarios. So our first patient is a patient with high-risk myelofibrosis who wants to pursue aggressive treatment. Our patient's name is Max. He's 62 years old. He has high-risk primary myelofibrosis using the DIPS assessment, DIPS plus rather. He's got marked splenomegaly and constitutional symptoms. While there are a wide variety of symptoms, I think it's important to note that when we're using the prognostic systems, the constitutional symptoms they're specifically referring to are night sweats, fevers, and weight loss. He's being evaluated for allogeneic hematopoietic stem cell transplant, but requires symptom control and spleen volume reduction while awaiting donor identification. He has a baseline splenomegaly with a palpable spleen of 12 centimeters below the left costal margin, which leads to abdominal fullness, discomfort, and early satiety. We've got some of his objective data points, including his mutations, the ASXL1 and SRSF2, as Sarah mentioned, being the high-risk mutations. We can see he's got some leukocytosis. His hemoglobin is a little lower than I would expect, at least on our lab, but holding in there, and then his platelets are 290,000. And he does have peripheral blasts, which can also increase the prognostic score. So we're going to start with a little discussion, which I think is going to be personally my favorite part. And we know his goal is to go to transplant. He's a young guy. I know we said elderly is 65, but in my thinking, he's a very young guy. So transplant's definitely going to be a top of mind part of discussion for him. It's also in line with his goals. He wants to pursue an aggressive treatment because we know that transplant is the only curative option we have for myelofibrosis. So the question becomes, based on how he's feeling, what's going on with his counts, the presentation of his splenomegaly, does he need JAK inhibitor therapy for symptom control before thinking about transplant? To me, I think absolutely yes, but I'm going to pass it to my colleagues and see what you think.
Yes, I would agree 100%. We've had conversations about this in our prep meetings in the sense that these are patients that are never going to get to remission, which is often a criteria to go to transplant. But what is critical for these patients is to optimize their status. And in some patients, he doesn't sound too debilitated. He's got a performance status of 1, but some of these patients are so debilitated from their symptom burden that they're not really at a great point to go to transplant. So trying to reduce the spleen volume, improve their total symptom score, which are primary endpoints for every clinical trial, is really critical to optimize them prior to transplant because they're going to do better. We know people that are really sick and debilitated don't do as well. It has to be an allo, so that's important.
I agree, and that big spleen is like part of his disease. So we know that when we take patients to transplant who have smaller spleens, they do better post-transplant as far as being able to cure them, which is what this guy's goal was. He wanted to be cured so he can go back to spending time with family and the things that are important to him, being able to do those. So, and usually, it takes a while to get to transplant.
Yes.
So I think he's going to be more than 2 months before he can get to transplant. So he needs some therapy to bridge him there.
Yeah.
Totally agree.
Absolutely. I think we also know that splenomegaly can compromise engraftment, which is part of why it's often a goal for transplanters to optimize patients by maximizing spleen volume reduction ahead of going into it. So I think That being said, there's often a disconnect sometimes when we're counseling patients, and they'll say, if I start on therapy, does it mean I can't go to transplant? So I'm curious how you guys would choose to counsel him on treatment expectations in this situation.
So I think JAK inhibitors often play a role post-transplant now, and so it is something that they're likely going to see over a continuum of their disease and transplant recovery. And I think just explaining what we've just discussed, where, I mean, I know in our institution, we're really working on our formal prehab program, pre-transplant optimization, just like you would do for someone going for a major surgery. And so really just beginning that conversation about being as fit as possible, and this is going to help with your symptom burden, which I think is unique to myeloproliferative neoplasms, particularly in that it is a primary endpoint in clinical trials. So it's really critical to be able to describe that to the patient.
Yeah, I really love the idea of prehab.
Yeah, me too. Yeah.
I think that's a really nice way to characterize it, and symptom optimization really goes a long way for patient success during transplant. You know, they're isolated for at least 4 weeks in the hospital. We often tell them the better you feel, the better you'll do.
Yeah.
Right. And we know it helps with fatigue.
Yeah.
Right? They're like, I'm really tired, and you're telling me to go exercise?
Yeah.
And, just start small and set goals for yourself. And then my husband likes to say, that's all you nurses say is, eat less, move more. And I'm like, well, we're trying to help you. That's what we do. And as far as this gentleman, his expectations, like his blood counts are going to go down.
Yes.
So that's not a sign that you're failing and that this is bad for you. Your blood counts are going to change. Your hemoglobin's going to drop. But he's got room there. So, just explaining, like over time, your normal for your hemoglobin is going to be lower. But he probably won't need blood transfusions even on therapy. And that we do have... we have choices in therapy now that, so.
It's a whole different world than it was 10 years ago.
Yes, it's nice, it's exciting.
Yeah.
I agree.
We also often tell patients objects in motion stay in motion, which is not a nursing thing. It's it goes beyond us. So,
Right.
I think a lot of good conversation to be had with this patient. So if we were deciding to proceed with ruxolitinib, and we'll go a little bit more into which JAK inhibitor you might choose and why, but if we focus on ruxolitinib, how would you initiate and then adjust the dosing based on response or toxicity? I think for me, the first thing that comes to mind is, of course, the labeling for ruxolitinib. He has a platelet count of over 200,000, so the recommended dose is 20 milligrams twice a day. My goal is going to be to try to get him at that dose and keep him there. But I know in practice we often see sometimes it takes a little lead-in. I'm curious what you guys tend to see as the most common approach.
Yeah, no, I agree with you. The other main parameter is renal function, and 62 is young in my mind in the world of cancers. And then hepatic, we don't know that based on his labs, but those would be things that would require dose adjustment. I think you're going to go through that in more detail, Catherine.
Mm-hmm.
Yeah, I think, we have the beauty of having 5 different dose levels of ruxolitinib, and we know that the higher the dose, the better it reduces the spleen volume and improves symptoms. So I would start with the recommended dose and then monitor his response and adjust the dose, but try really hard to keep him on the dose that's recommended to shrink that spleen as much as possible and improve symptoms.
Yeah, I would agree. Okay. And then I think our last question for this case for now is, how would you map out lead-in time and overall care delivery as this patient prepares for the transplant process? I think an advantage of starting a JAK inhibitor around the same time that the transplant conversation is really ramping up is that we're going to bring them in for monitoring through the course of their initiation with the JAK inhibitor. So it can be coordinated with our transplant colleagues in doing all of the pre-transplant testing, and also get a better sense of how they tolerate therapy across the board. The JAK inhibitors, the goal is to improve symptoms and splenomegaly. Patients do usually tend to report that they feel better, but if we find that they're struggling with side effects or symptoms, that's a good thing to know leading into transplant where the therapies can be more intense. I also think it's important, like Sarah said, there's some great graphs from the COMFORT study that I have been known to draw on my exam table about when you would expect the nadir. Yeah. Managing cytopenias is incredibly challenging for patients with MPNs, and we know that when we initiate JAK inhibitor therapy that we're going to have usually some degree of reduction. And it gets, sort of hits its lowest point at around the 2 to 3 month mark. So we can help coach patients through what to expect and what it looks like. What do you guys think?
I agree. Setting expectations is really critical because when you do that, and it's great. I also draw on exam room table paper. Then when that happens, you can say, remember, we talked about this, we expected it, it's not, this isn't unexpected, in other words, and we can get through this, and here's what we're going to do to help you.
Yeah, and one of the things I think about, sorry, I'm trying to cough here, as far as lead-in time for some of the therapies, well, for many of them, you don't want the patient to have a rebound in their symptoms. Yeah. So we can taper the drugs to where they either, some patients stay on them. You were talking to us about that at your center, stay on their therapy for their JAK inhibitor during the transplant period. But what we've done older, like previously, is a lot of places taper down the JAK inhibitor therapy, and then like the day before transplant, that's their last dose, so they don't get a rebound in symptoms.
Yeah, absolutely. It's got a pretty short action time, so it's easy to do a one day to the next, but it's important to be careful about how we start to come off. Okay, we're going to get into some data points. So this is a schema of the NCCN guidelines, something that we use in practice really often. There are 3 primary things that I want to point out from this particular slide. I think Sandy's going to have another good slide with an overview of the guidelines. And it's a really helpful thing, I think, for nursing and APPs to utilize when we're going through what our options are for our patients. The first thing, because we're really focused on the transplant conversation for Max, is this guidance about transplant. So if a patient is a transplant candidate, it's recommended that JAK inhibitors be considered for use in patients for at least 2 months prior to transplant, particularly in patients with splenomegaly and or constitutional symptoms, which our patient has. JAK inhibitors, just like Sarah was saying, can be tapered prior to or during conditioning so that they're completed before cell infusion. So it's very reasonable to utilize these tools leading into a transplant. The other 2 things I want to point out. First, you're going to see clinical trial listed at almost all of the points of NCCN guidelines. I am a clinical trialist, so I get very excited about that, particularly because you also see that we really only have these 4 options for our patients. So incorporating conversations about clinical trials is, I think, an important care piece for all patients with MPNs across the board. And then the next piece, because this sets up where we're going to go in conversation, is that our patient is a patient who has a platelet count greater than 50,000, and he's symptomatic and has splenomegaly. So we're going to follow this part of the schema and really focus on ruxolitinib and fedratinib, which are our category 1 recommendations. So we'll start with ruxolitinib because it's the original, the OG, if you will, looking really at the COMFORT trials, which are data points that often are at least a part of the conversation at some point through the course of all patients with myelofibrosis. Our graphs here on the left really show the degree of splenomegaly or spleen volume reduction compared to either placebo or best available therapy. The threshold for improvement was measured at a spleen volume reduction of at least 35%, and it's pretty clear that ruxolitinib outpaced the alternatives in both cases in a significant way. There's also significant degree of symptom improvement observed. In the COMFORT-1 studies, about almost half of the patients achieved a 50% reduction in symptom score, so had an improvement in their symptoms by at least 50% while they were taking the ruxolitinib. And in the COMFORTS-2 study, we saw significant improvements in MF-related symptoms with Rux compared to best available therapy. At the time, the best available therapy options were a little bit different, and I think that's also an important part of the conversation. Ruxolitinib was the first one around, so now we can use it as the comparator for a number of our studies as we go forward. Looking a little bit more at the dose selection, we sort of talked about this when we were talking about the transplant part of things. For a patient like Max who has pretty good counts going into this conversation, I think it's important to make sure that we're having conversations about dose optimization when we choose to start with our JAK inhibitor therapy. With ruxolitinib specifically, it does make a significant difference in terms of spleen volume reduction. Our dark blue shading demonstrates the response for patients who were on the expected dose, and that's expected based on the guidance really driven by platelet counts, and then our lighter blue is really for patients who are on a lower than expected dose. I do still think it's valuable that the symptom response is comparable, because if you have a patient who ends up with a treatment-related cytopenia and it's necessary for you to reduce the dose, I do think it's still really valuable for the scope of their care that we're able to garner some symptom benefit. It can be very challenging when patients don't feel good, so it's still valuable to be able to use ruxolitinib even if you're not able to get the maximum dosing. But as far as our coaching, our guidance, and our treatment goals, that difference in the achievable spleen volume response is significant and goes a long way for fitness for transplant beyond just the symptom improvement. Okay, and then switching gears, now we're going to talk a little bit about fedratinib. This is looking at the Jakarta trials. Similar to ruxolitinib, we see that it had a good amount of spleen volume reduction, about 40%, especially when compared to placebo. And then with my lighter blue, I think this one is particularly important. At the time ruxolitinib was studied, it was the only one in the pipeline, but when fedratinib was being evaluated, we already had ruxolitinib to compare it to, and so we were able to use patients or utilize a post-Rux study, so see if patients could continue to have some degree of spleen volume reduction or symptom improvement following the use of ruxolitinib. And with that said, the data did demonstrate that there was still at least a 30% reduction, continued reduction in spleen at 6 months, which is, I think, really important, because even if you choose to start with ruxolitinib, if you need to, for whatever reason, make an adjustment down the line, transplant isn't always straightforward. Our goal is to get them there quickly, but donor alignment, life goals, all of that can get in the way. So to have multiple lines for discussion when you're talking to your patients, I think is really valuable, and to understand how they work sequentially can sort of impact our plan for our care. Also similarly, about 40% of patients treated with fedratinib achieved that 50% reduction in TSS at the 6-month mark as well. Okay, some dosing considerations. So we talked a little bit about the ruxolitinib dosing. The starting dose is really based on the platelet count. So patients with platelets greater than 200,000, the recommended dosing is 20 milligrams twice daily. And then you see that the dose reduces based on the platelet count as it goes down. Fedratinib is a 400 milligram once daily. Sometimes that once or twice daily can make a difference for your patient, so I think that's a valuable part of the conversation, especially for nursing as we're doing our coaching on our options as we go into it. Both of them have guidance for reducing the dose based on thrombocytopenia or anemia, and just like Sandy mentioned in the beginning, making sure that we're mindful of the renal and hepatic function of our patients. Okay, we've got a question. So rethinking the choice, how important is achieving recommended ruxolitinib dosing for maximizing clinical benefit in myelofibrosis?
It's ominous music.
Very serious, choose wisely.
Yes.
This is morning music.
Oh yeah.
Yeah.
Get up ready to start
Wake
your
us
day.
up.
Yeah. I was saying this morning, I was rethinking the question, and I think one of the things that comes up often for me, at least, is that I feel like everybody's MPN is a little bit different, and it's hard to have a one-size-fits-all answer. So even looking through these options, I could see where, option 2, option 3 really can hit different depending on how you absorb it and which patient you're thinking of top of mind. But I agree, I think the takeaway really is that maintaining the maximum dose for clinical benefit is critical for optimal spleen response and symptom responses as well. Okay. So also want to look at our safety profile. I think for nursing in particular, we really do a lot of the guidance and have so many of those conversations. We were just talking about a patient who so rarely sees their physician because we've become the front line. So really understanding what the dose-limiting features of some of these medications can be, the key adverse events to monitor, our cytopenias being first and foremost. GI toxicity is another thing that we consider with fedratinib in particular. There's a lot of guidance on how we can approach that to make it tolerable for patients, and I think in both cases it's important to note that the toxicities do improve over time. Usually we're able to manage. For the unique safety signals, fedratinib does come with a black box warning for Wernicke's encephalopathy, so it's important when we're starting patients to check thiamine levels at baseline, and then as they're going through therapy, we sometimes will utilize thiamine supplementation as well. And then managing our GI toxicities prophylactically. With ruxolitinib also, we often talk about infection management, making sure that they get their vaccinations either before they start therapy or shortly after they start therapy, but to make sure that we're being really mindful of those live vaccines. Okay. We also do a lot of medication reconciliation in the nursing world. So a couple key drug-drug interactions to be aware of with JAK inhibitors. Both of them want to make sure that we're paying attention to that CYP3A4 pathway, making sure that we're asking patients about all of the medications that we're taking, some specific ones, the azoles, the macrolides, and anticonvulsants, and herbal supplements. Herbal supplements are something that I get asked about often. There is, I think, an app that we can use sometimes if patients have questions about the utility. They're not studied in the same way, but can be very valuable. But there are a number that we know can cause interactions. And then also everybody's favorite, that grapefruit.
Yes.
Gotta make sure that we're being cautious with the grapefruit. Okay, so a little bit of a recap focusing on Max. He's a 62-year-old patient with high-risk primary myelofibrosis, marked symptomatic splenomegaly, who's being evaluated for allogeneic transplant and requires rapid symptom and spleen control while awaiting donor identification. A couple key things: addressing the myelofibrosis symptoms, particularly those related to splenomegaly, can improve the chances of optimal outcome pre-transplant. JAK inhibitors do play a key role in controlling symptoms and reducing splenomegaly, as we see from the evidence with both the COMFORT and JAKARTA studies. We do usually counsel patients that the better you feel, the better you'll do. Objects in motion stay in motion. And nurses can engage with the transplant team and lead the monitoring strategies. I think it's really something else that we do so well is the care coordination, making sure that we're keeping everybody on the same page. We really steer the ship. So having honest conversations with the feedback we get from patients about how they're feeling, what our approach for monitoring is, and what their plans are for getting them to the actual transplant. Really a big role that nursing can play with that. And then when we're using JAK inhibitors prior to transplant, using the standard dosing and CBC monitoring protocols will be really valuable for the care of our patients. Okay, got another question. A patient with high-risk myelofibrosis awaiting transplant has symptomatic splenomegaly and constitutional symptoms. How would you now counsel this patient on their next steps? Okay, almost at 90. There we go. 90% are going to recommend starting JAK inhibitor therapy and monitoring response and tolerability, which I think is much like what we'll see in the clinical setting for our patients with MF. Okay. And then we're going to shift gears just for a moment to talk about improving on JAK inhibitor platforms in myelofibrosis. I mentioned clinical trials. That's the space that I practice in. And I think it's an important part of the conversation just as much as having the JAK inhibitor conversation. In my setting, I'm in an academic center, and often when we send our patients to transplant in the first place, the transplanter will come back and say, what are you going to do to optimize them, and have you talked about your clinical trials? What options do you have? So with that, there are a number of newer agents being evaluated. The last I checked, I think there's about 50 enrolling clinical trials across the board for MPNs in the United States. But really, I want to talk about these quick two that are in slightly different stages, but I think are going to be valuable parts of the conversations for MPNs and myelofibrosis specifically as we go along. The first one is a medication called pelabresib. It's the study name is the MANIFEST-2 trial, is the phase 3 study, where it's found to be very valuable as a combination therapy with JAK inhibitor. It was evaluated in patients who were maybe not treatment naive, but JAK inhibitor naive. And I think for our spleen volume reduction conversation, the most important note is our graph over on the right that really shows that when patients had pelabresib with the ruxolitinib, they got a much deeper spleen volume response with the combination therapy. For our patient Max, he's got a decent amount of splenomegaly, but we sometimes see spleen volumes that can be over 2,000 mLs, which is really significant. And for somebody whose goal is transplant, the more we can do to maximize spleen volume response, the better off they're likely to be. Common AEs, again, are cytopenias, some of that diarrhea, a little bit of dysgeusia or the change in sense of taste, usually well managed. And then similarly to when we would start patients on ruxolitinib or fedratinib alone, we want to make sure that we're monitoring their CVCs early and checking on their symptoms and tolerability as we go along. And then the next one, this is actually in a phase 1 study. INCA 033989, it doesn't even have a name yet, but it's a first-in-class antibody targeting mutant CALR that represents a novel non-JAK therapeutic strategy for myelofibrosis and ET. So the CALR mutation is one of our 3 driver mutations, as Sara mentioned earlier on in the presentation. And I think this is particularly exciting because MPNs have sort of just started the game in the mutation-directed therapy. I know this image is a little it's beautiful, but it's a lot to absorb. So I'm going to focus, if I can, right here first. And what we're looking at, this is where we see the mutation. And what that causes is the signaling activation of the inflammatory component of the disease. Where the antibody comes in, just like antibodies do, is it binds to the mutation, the CALR component of the mutation, and breaks it up or sort of puts a cap on it to stop that action. So with that, what we've seen in this study for our folks who've been able to participate is that it's been generally well tolerated. Most antibodies, I have a physician who likes to call them clean because they're really just focusing on the mutation component, so it's been well tolerated. There haven't been any dose-limiting toxicities, and we've seen similar improvements in spleen size, symptom burden, and anemia. Interesting also that this study is being evaluated in folks who have not been on JAK inhibitor therapy before, folks who have been previously treated who are relapsed or refractory to JAK inhibitor therapy, and then also they've expanded to now have a cohort for folks who will be doing it in combination with JAK inhibitor therapy. So I think a lot of forward motion in terms of our scientific development for focus on MPNs. Obviously, make sure that we're monitoring those AEs, but I think a lot of promise coming down the pipeline. And now I'm going to pass to Sandy.
Thank you.
Perfect.
Yes. Okay, we're going to now shift gears a little bit, and we're going to talk about Barbara. And so Barbara is a 71-year-old woman with JAK naive, so has not had a JAK inhibitor, post-PVMF. And so we know that myeloproliferative neoplasms are basically ET, essential thrombocythemia, as Sara said earlier, PV, polycythemia vera, and myelofibrosis. Both ET and PV are basically on a continuum, and over time, the risk is to transform into myelofibrosis, and then all of these diseases can jump the fence and become acute leukemia. And so I explain that to patients. That time frame can be long, particularly in ET, but also in PV. Barbara has fatigue, moderate splenomegaly, and symptomatic anemia. And interestingly, there was a delay in making the diagnosis and confirmation of myelofibrosis. The only way you can do that is with the marrow, because you need a core biopsy to actually see that fibrosis, and that fibrosis is graded from MF1 to MF3. And in order to meet that criteria of myelofibrosis, you need MF2. And so you can't diagnose it any other way. There was a question in some of the questions coming in about that. So it isn't unusual for patients to be diagnosed with PV, polycythemia vera, just by doing a JAK2 mutation analysis on peripheral blood. And this happens a lot, and the patients may never have had a bone marrow biopsy. So it's really important to understand that, I think, in the diagnostic process. So there was a delay in her treatment. She's had hydroxyurea, which is a standard cytoreductive therapy for polycythemia vera. But now, as Sara mentioned, people's marrows start to burn out, and you begin to see progressive splenomegaly, but also the progressive, typically anemia. Some patients we see predominantly thrombocytopenia, but mostly, more commonly in PV particularly, we begin to see anemia, and she's now become transfusion dependent. So she's having increasing transfusion burden, going from 6 to 8 weeks, but now requiring it every 2 to 3 weeks. Along with that comes progressive fatigue, reduced stamina between transfusions. We're going to talk way more about anemia and transfusions as we go through this. You can see her mutations. So she has the JAK2 V617F mutation and ASXL1, which we have already heard is a high-risk abnormality. White count's elevated. Hemoglobin is reduced, 8.5. I don't know when her last transfusion was, so that may be a factor in interpreting that. Platelets are okay, just a little below normal, and she has 1% peripheral blasts. So, discussion. How would you plan to educate this patient on their symptoms, anemia, and the prognostic impact of transfusion burden? So, who wants to start?
I can start.
Okay.
I guess. So we know that when a patient has to be typed and crossed, scheduled for a transfusion, and we have a transfusion unit that's always full, and we have a hard time getting patients in for transfusion, that takes a lot of time for them and takes away from their family time. And so just helping her work through that, also scheduling.
Yes.
That takes a lot of effort and frustration for patients. The first step we would normally do before she became really, being transfused every 2 to 3 weeks is check an erythropoietin level. And if she's less than 500, try a little epoetin.
Yeah.
Yeah, that would be our first step. And then explaining, okay, this is a hormone made by your kidneys, and we're trying to improve your hemoglobin and decrease your transfusion requirements. And we would usually start that when they're around 10 and not wait till she gets really transfusion
Into the
dependent.
8s. Mm-hmm.
Yes.
Yeah, I think especially with the speed at which this has changed for her, it's worth having a conversation about the value of transfusions in this setting. I think she already has fatigue, and with fatigue and MPNs, it's multifactorial. It could be driven by the inflammatory component of the disease. It can also be driven by the anemia. So just having sort of a full scope conversation about how she's feeling and what might be contributing to that, I think, is going to be important. And then also the scope of transfusions, why we use them. I have often patients will come in and say, well, I feel, I'm tired, but I feel fine. Why do I need to be transfused? Because there's a concern about getting transfused and the complications that can come with. Iron overload is a piece of the conversation we often have. But I will usually make sure that patients know that if we don't transfuse you, then first of all, you become very tired. You can be short of breath, and then it has cardiac complications. We're making your heart work a lot harder than we'd like it to, trying to get that oxygenated blood around your system. And just like you're feeling fatigued, your bone marrow is feeling a little fatigued, we need to do something to boost things up.
I think the other thing for me in this particular scenario, and patients who really haven't had a complete workup, and we see this still fairly often, is they have a misconception that polycythemia vera is just a blood problem. Mm-hmm. And years ago, these diseases, they went from being called disorders to neoplasms for a reason. You see mutations. By definition, that is not normal, right? So these are cancers. And so one of the conversations I think I would have with Barbara was really helping her understand where she is on this continuum, and you can tell I do this a lot with my people. Like, you're over here, we don't want you to go over here, and we don't want you to jump over the fence, right? And just really laying that out for her, because this is a big shift for her. And prognosis in people with ASXL1 mutations, way more likely to transform to leukemia. So really having her understand that this is a cancer, that's why we are going to try to choose things to treat her specifically when we talk about personalizing therapy, helping people understand how we go after that JAK-STAT pathway to control both the inflammation, but also improve splenomegaly, improve symptom burden, hopefully get the marrow working a little bit better to overcome some of her symptoms. What other conversations would you guys have with Barbara about personalizing her treatment?
First and foremost, I don't think that Hydrea is serving her anymore,
Yes.
so we got to talk about something
Yes.
else.
Right.
Yes.
And then secondly, I think really getting a good understanding. There's a conversation ongoing, I feel like, for many years about what's important to patients versus what's important to providers. So having the match conversation about what does that hemoglobin mean for her. You know, the evidence says that we transfuse in the 7s. If she's feeling that fatigued at 8.5, is that, you know, an adjustment to our plan? What does that look like for her? You know, she's feeling more fatigued in between the transfusions. Should we be doing 2 units versus 1? Getting a better understanding of what the impact of the transfusions is for her in their success or not.
I think that's a really good point. As I typically will ask patients, did you feel better after you got
Yes.
the
Yep.
transfusion? Were you able to do more with your family? Like, how does it really impact their day-to-day activity? So I think
Right,
that's a
so
good
treat
point.
the patient, not the chart, like not the computer, right? Like, what does that number mean to you is a really good way, and how do you feel at that number? And patients are comparing notes in the, you know this, in the clinic.
Yes.
They're like, well, why did she get 2 and I only got 1?
Yep.
I almost never give 2 units, almost never, unless you're in the 5s or 6s, because we're going to talk about some of the risks associated with transfusions, and the benefit is temporary. These are borrowed cells, and depending on how long that's been sitting on the shelf, you know, that unit may give you different relief, both in terms of the hemoglobin response, but also in terms of symptom improvement. So now we're here, and she's JAK naive, so has never seen a JAK inhibitor. So if we're starting momelotinib, and we're going to talk more about the clinical trials around this, how would you proceed with preparing a safety and dose optimization plan? So we're going to kind of get ahead of ourselves in talking about this before we look at the data. But Sarah, I'll start with you. You're going to start someone on momelotinib. How do you have that conversation, and what is your approach?
Well, we could tell her why we weren't, why we chose momelotinib.
Mm-hmm.
We're trying to decrease her transfusion burden. It's shown to really be better for patients who have anemia because it has a different,
Mechanism?
a different mechanism of action, not just JAK inhibitors, but ACVR. And then also talking about what's going to happen with her blood counts in the beginning and the need for monitoring her closely, not just during her transfusions, and then looking at her chemistry profile too, and that we're probably going to need to dose adjust as we go along.
I think I would similarly, and then I also think similar to the conversation about ruxolitinib, wanting to make sure that we're focusing on trying to maximize the most tolerable dose for her. I think for patients, especially those who've been on hydroxyurea, which has a more fluid dosing strategy sometimes, it's valuable to include in the conversation the way that we're hitting the different targets. I really like the slide we have on the different mechanisms of action. Hydrea, we know, is an indiscrete sort of MOA, whereas momelotinib is a little bit more targeted, and how that plays into us really wanting to maximize the dosing and what it's anticipated to do for her treatment across the board.
It's interesting that you say that. This is not on this slide, but there's a question here that talks about, what if people's, their counts are doing okay, but their symptom burden isn't changing. And I think that's a really important conversation. Hydrea does nothing to the inflammatory pathway that is upregulated in the JAK-STAT pathway, it really is cytoreductive. You're basically just bringing counts down. And in PVERA in particular, you really are trying to control all 3 cell lines, which is necessary to reduce the thrombotic risk and optimize their care. And so really, we do talk about mechanism of action with patients and try to help them understand. It can be confusing. But I think it's important for them to understand why it's important to take their pill every day. These are pills.
Yep.
We rely on them to dose themselves. You want them to really be getting the therapy that will help them the most. And then secondly, what would your outreach strategies, how would they change if she presented with thrombocytopenia instead of anemia, or had presented with pancytopenia? And there are patients who truly had their marrow burns out. And then you're starting with low numbers and you're struggling with, is that because of splenomegaly, the degree of fibrosis in the marrow? I think restaging patients is really critical. If this person were on a JAK inhibitor and you were having this conversation about moving to something else, you need to know where their marrow's at. So those would be things that I would think about. Platelets are way more tricky because they are very short-term. Transfused platelets really don't offer much leverage, and people become alloimmunized over time. They're exposed to more and more antibody as you're transfusing them. Both for platelets and red cells, you can have a lot of antibody formation. It's really hard to find units that are going to match. Anything to add for that, you guys, in terms of thrombocytopenia?
Well, we do have like momelotinib that's mainly been
Yes.
targeted or marketed as
Yes.
for people who have anemia, and then we have pacritinib
Yes.
for platelets less than 50,000. So you do, we may use pacritinib or momelotinib in this patient's case, but it's really hard. I think it's really hard, and if you
Yes.
go exactly by the guidelines, if a patient's having a spleen volume reduction and it's making them feel better, then I might even try to keep them on therapy and transfuse them.
Yes, yeah.
And then I've seen it kind of stabilize over time. And she might have went from 40s to 30s, but if
Yes.
she stays stable and she's needing less transfusions and having a benefit, then I've kept patients on a lower dose of momelotinib, but not, like, I think I had a patient that went to 13,000, and then I'm like, I just monitor her closely for signs and symptoms of bleeding and transfuse her.
And I think low platelet counts make people very uncomfortable,
Yeah.
especially in rural settings where we're very spoiled. You can come, have your labs, get blood, platelets all in the same day. And that's not the norm a lot of places. Even in big cities, I'm always amazed at the time it takes to get a red blood cell transfusion between the lab, somebody to look at it, or the type and cross, have you maybe go somewhere else for your transfusion other than your own center, which is really a reality. So it does become complicated. I mean, you deal with low platelets all the time, but
It's very challenging. I think, we're talking about the JAK inhibitors, but with anemia, we also have a number of other supportive
Yes.
options that we just don't have for platelets, and it becomes a dose-limiting issue. I think also, to Sarah's point, recalibrating expectations for the care team as much as for the patient, that if we hit 45, we may not be trying to get to 150 again. It's, we're living at a different pace.
That's a really good point, is, again, setting those expectations about what do we expect. We want to get you just to a safe level, reduce the risk of bleeding. So let's talk about some of this. So let's first focus on anemia. So it significantly affects symptoms, transfusion burden, and survival. We know that transfusion dependence is associated with inferior overall survival across diagnoses. And there's a lot of speculation about why that might be, chronic, sort of mild hypoxia, upregulation of inflammation, nitric oxide and other things. Over time, we've learned a lot of this in the myeloid malignancies where this is a primary problem. But across the board, transfusion independence is associated with reduction in overall survival. Iron overload is the other risk that comes with repeated transfusions. So you can see here RBC transfusion independence, approximately 8 years versus transfusion dependent 2.6 years. And then grading of the anemia based on hemoglobin levels. Patients may have different numbers here in terms of how they feel at different numbers. And I think, Catherine, you commented about like how do you differentiate the inflammatory component of MF versus anemia, and it's very difficult to sort that out to understand, particularly the cause of fatigue. And so it's important to really look at the numbers over time. I graph things all the time. It's my favorite thing to do in the computer and show the graph to patients to say, here's where we are, this trend is changing. This may be a reflection of the progression of your disease or improvement in your disease, whichever the case may be. We talked a little bit about some of the other options. I'm going to go into that briefly about anemia-directed therapies in mild anemia, and so transfusions are one option, but if we can, we like to optimize the bone marrow's capacity to produce red blood cells on its own, if that's possible. Those drugs don't always work in someone who really has significant fibrosis by virtue of that's just scarring in the marrow. But then also using the treatment or disease-directed therapies to shrink the spleen and try to optimize, again, the bone marrow function. And then in a severe anemia, this gets a little more tricky, but we do, really begin to look more at those directed therapies. So here's a question. Which treatment goal do you now think is most relevant to discuss with patients, Barbara or others, who present with MF-associated anemia and increasing RBC transfusion needs? Elimination of all constitutional symptoms, achieving transfusion independence, and reducing transfusion burden, immediate normalization of blood counts. I'm not sure how to cancel this patient, so take a minute. Okay,
Love funky.
while you rock out. Excellent, yes, okay, yay. Okay, so we're back to the NCCN guidelines, and you can see MF-associated anemia, not controlled, clinical trial, yay. Always the right answer, always the right answer. On a JAK inhibitor with controlled disease, is there a clinical trial? Clinical trial is always preferred. We don't have enough options. And I always explain to patients, the way I explain it is this offers you an option that you would otherwise not have at this point in time. We can always do standard of care, but this is an option that you would otherwise not have. And you get a lot more attention when you're on a clinical trial because there's a bunch of people following you around, right?
Yes.
Whole team.
Yep.
So it's
Safety
really,
net.
yes, and so that's really important. And the people that go from one trial to another get used to that, and then when they're not on a study, they're like, where is everybody?
Yep.
Right? Like, what happened? Where's my team?
Yep.
So really important. But you can see, ruxolitinib-based therapies on a JAK inhibitor, controlled disease, are a strategy. But then you see these supportive agents. So there's luspatercept, which is a trap ligand. It works at late-stage erythropoiesis. So as the cells are maturing, it works at this very end to help that process of red blood cell production. You heard about erythropoietin. It is not helpful in people that have high EPO levels because they have plenty of their own. You're making it in your kidneys. Danazol, which has been around for a very long time in my entire career, and so still can be used. I think as we've have these newer options, that's become less common. But I'm going to share with you a study where that was the comparative arm because it is part of the conversation. And then useful in certain circumstances if anemia persists or worsens is to think about these other agents, momelotinib and pacritinib, which I'm going to talk about next. And then similarly, the group with low platelets, specifically looking toward pacritinib. So let's talk about momelotinib first. And again, here we have those primary endpoints, spleen reduction and symptom response. And so this is basically comparing momelotinib to danazol, as I just mentioned. And you can see the significant difference between spleen volume reduction and total symptom score reduction in the patients receiving momelotinib compared to danazol. So pretty much hands down, significantly improved for both of those endpoints. In this study, there's a crossover, and that's true of a lot of studies where we're finding newer drugs in more rare diseases, and so really offering a patient the opportunity to cross over. And so if they were randomized to the danazol arm and they're in these lower bars that you can see, they had the opportunity to cross over. And so you can see the danazol in gray here. This is danazol crossed over to momelotinib. But you can also see how significantly improved those responses become once they crossed over to the momelotinib arm, and also demonstrating durability and improvement over time. I think that's the conversation also to have with patients in drawing things on the graph paper or on the exam room table, is that some of these responses became better over time. And this is another way to look at that. So momelotinib improved symptom burden, anemia-related quality of life in the Momentum trial. And again, we've talked about the trade-offs with transfusion dependence. So becoming transfusion independent is really significant. People are tethered. They're with you all the time, getting labs, getting typed, getting blood, and then however long that improvement is in their counts, they're back to it. And so to have them travel, I mean, we've tried to arrange transfusions in Singapore and it's very, very difficult to try to get people blood somewhere else. Even just in California, trying to find a place where a person could go on vacation, and other than just going to an emergency room, you can't just go to a cancer clinic somewhere because you're not a patient there, right? And so it becomes very tethering to patients, and that doesn't sound like a lot, but it really is from a quality of life perspective, that sense of some level of freedom. But again, you can see the difference here between week 24 and week 48, and all of the degrees of improvement in symptom control, in quality of life and transfusion independence over time for these patients receiving momelotinib. So excellent outcomes there. So we're back to our NCCN guidelines, and if you shift over to now where we have low platelets, you can see that pacritinib here is a category 1. If I go back to the anemia conversation, momelotinib has gained a category 1 designation in NCCN guidelines because of that improvement in transfusion dependency, but also spleen volume reduction. So here's pacritinib, which has category 1 in patients with thrombocytopenia. And what you're seeing here is a variety of doses were originally tested in this study. This is the PERSIST-2 trial. And ultimately what came out of that multi-dosing regimen is that the preferred dose is the 200 milligram dose, because of it, tolerance, but also achieving these endpoints. And this is compared to best available therapy, and there are a variety of best available therapies here. And what you see is spleen volume reduction and 50% reduction in total symptom score, favoring the pacritinib arm, and then also specifically in patients with less than 50,000 platelets, a big difference in those two outcomes as well compared to best available therapy. And then the proportion of patients much improved PGIC, which is a global score that a patient reported in outcome for how they feel. And so it's really them telling us, I feel better or I don't. You can see that 57% of the patients with pacritinib at the 200 milligram BID dosing versus 28% with best available therapy. So patients felt better. These are the dose adjustment recommendations. So again, recommended pacritinib dose, 200 milligrams twice daily, can be used in the lower platelet counts. You can see some QT prolongation, so that's something to monitor, and certainly looking at the other drugs that patients are on. Avoid in severe renal and hepatic impairment. That's pretty much across the board for these drugs. Momelotinib, the recommended dose is 200 milligrams once daily. If severe hepatic impairment, so the Child-Pugh class C, I always have to look that up because that's not my thing. But that's the beauty of technology, right? Like, what's a Child-Pugh C? I couldn't tell you off the top of my head. I have to look it up. But you can still give the drug at a reduced dose. So, question, a patient with symptomatic MF, associated anemia is starting momelotinib. Which initial approach would you now recommend? 100 milligrams once daily with planned escalation, 200 milligrams twice daily during the first treatment cycle, 200 milligrams once daily with ongoing CBC and symptom monitoring, or for intermittent dosing based on transfusion requirements. That's a happy song. Okay, very good. So 200 milligram once daily with ongoing CBC and symptom monitor would be the preferred option here. So as always, drugs do come with potential adverse events. I think universally we know cytopenias can happen with these drugs, so the conversation previously, things might get worse before they get better, setting those expectations. Time to response, when do we expect that peak response? Things can improve over time. Having that conversation is really important at the outset, and then reminding them about that conversation as we work with them. I mentioned QT prolongation, minimal myelosuppression, less so with pacritinib, but caution in those with cardiovascular disease, and then because of the QTc prolongation. And then for momelotinib, can see some diarrhea, nausea, easy in most cases to control. You heard about the activin receptor 1 inhibition in an earlier conversation, which is a different way, a mechanism of action. This then, changes the hepcidin level, which is part of what helps to regulate iron availability. So by freeing up that iron, this drug can, by virtue of mechanism of action, improve anemia, and which is why it has the approval that it does. And then peripheral neuropathy is, in my experience, has been not like we think about in the taxanes or the other drugs that we give in other tumor types, but it is something that is reported in the trials. For all of these drugs, we need to be monitoring LFTs baseline and periodically due to potential liver concerns. And then any oral drug, this is where you phone a friend, usually a pharmacist. But also there are great tools. So our embedded drug resources is Lexicon, and there's a wonderful interaction tracker, and you just plug them all in there, and they tell you which drugs get along and which don't. But often, we also have a very robust oral therapy program in our center, and so we have a whole team that helps to monitor these patients, get the assistance programs going, all the things. And so we rely a lot on them to do this kind of work, to see, sometimes we have to call one of the other ologists and say, can we change that drug? Can you stop their flecainide or their amiodarone or whatever it is, because that drug's not going to work well with this. And they're usually willing to work with you, so it might take that. So in recap, Barbara, a 71-year-old woman, JAK-naive, post-PPMF, symptomatic. We need to really have that conversation about what that means, talk about MF-associated anemia, and transfusion dependence, have conversations about the impact of transfusion burden. JAK inhibitors such as momelotinib can help reduce transfusion burden while improving symptoms, so really important to think about our focus and outcomes. And then baseline thrombocytopenia, the preferred drug category 1 is pacritinib. Again, and then cytopenic MF, don't treat a number, treat the patient. So the last slide I'll just show you here is really the dynamics of MF, and it's continuous and multidirectional. And again, people are on this continuum over time, and the pace at which that process changes varies by patient based on their risk category. I think interestingly, when you look at all those, the MIPS, the DIPS, the IPS, there's something called MySEC, which is what we used for post-PV and post-ET MF in risk stratifying patients. The age of 65 automatically puts you in a higher risk category. You saw in the early slide, the peak onset of this disease is age 65 to 69. So most of these people are going to have higher risk disease just by virtue of who's affected. And by virtue of that, they're going to have symptom burden. Understanding how we measure symptoms, Sara mentioned embedding tools in the EMR. That's not always easy to do, and your Epic is not my Epic. I wish I had Epic. We went from Epic to Cerner. That should never happen to I know. Thank you.
Groans across the room.
You feel my pain, right? So, but you know, it's hard to get those things built. It can take 2 years to get something built in the EMR. So it's on us as clinicians to be consistent in our language and be able to share that information across the continuum for patients. Really optimizing supportive care, having patients understand the temporary nature of transfusions and the importance and the risks associated with that. Ongoing education, this is to just be adapted as we go. We really need to engage our interdisciplinary team, really get other people involved, social work, if you have PT/OT, just trying to optimize their wellness over time. And then, you know, cancer is a team sport. So you really have to get caregivers involved, and in anybody that's considering a transplant, that's an essential or necessary thing. I really try to talk to patients about caregiver teams. So a whole team, not a person, so that if there's a primary caregiver, you get caregiver burnout. So really having these conversations, they also serve as the truth squad when the patient comes and say, no, I'm fine, and the person's like, no, you're not. So we'll close with this question. Following this program, what changes are you most likely to apply in your MF practice? More routine, check all that apply, more routine symptom assessment with MPN-10, earlier counseling on JAK therapies for symptom control, pre-transplant, earlier discussion of anemia, transfusion burden, more proactive JAK dose management. Little of everything, so that's excellent, which is the reality, right? It's not just one thing, it's really the whole experience, the whole treatment improvement. And with that, we'll turn it over to Sara, I believe, for Q&A. Thank you.
Thank you. Thank you for everybody that stayed. So I have some questions from people who submitted them online, and then we will also take some questions in the room. So I'll start with the online ones, and then if someone wants to give or present a question that's in the room, if you'll raise your hand, and we'll try to get a mic to you. So the first question is, can you give us some suggestions for long-term monitoring of patients on JAK inhibitors, and then any difference in what we should look for during early days of therapy compared to later on? So long-term monitoring of patients on JAK inhibitors.
Long-term monitoring, I think, is going to look a little bit different for everybody. I'm also pausing just because I think it's nice to have the concept of long-term monitoring for these folks. There's a model, the R6 model, that talks about what happens when we lose ruxolitinib specifically as an option, so a little stuck on getting to do the long-term monitoring. I think the counseling when you're starting will be quite different to when you have somebody who's 2-3 years in on a JAK inhibitor. For example, most of the treatment toxicities, the things like the GI toxicity or the cytopenias, they do tend to be worse in the beginning with each of them. So we're going to bring patients back a little bit more often when we're starting them on therapy, which I also think is just good for our relationship with the patient as well, so that we get a good sense of how they're doing. You know, especially if it's a new diagnosis or if it's a change in therapy, that can be very anxiety provoking. So bringing them in more often helps us get a better understanding of what the side effect burden is like, what's going on with their counts, and also just overall how they're doing with this change. I think the cytopenias also, as we talked about, do tend to level off. I think it depends on what profile your patient has. If there's somebody who came in very cytopenic and you were starting them on one of the later JAK inhibitors, a momelotinib or pacritinib, the leash for for bringing them back for observation might be a little shorter. Whereas for somebody who's, earlier in the process, maybe starting on a ruxolitinib or fedratinib, might be able to give a little bit more time and distance between visits as you get further along.
I think the other thing for long-term that I think about is if someone's been on a steady dose and doing well and all of a sudden their counts are trending, they need a marrow because we worry about progression, right?
Yeah, I agree. And paying attention to those peripheral blasts. Are they changing? And then some of the other long-term complications, unfortunately, that I've seen in patients that I've been following for years is the progressive liver failure that they get into, the cirrhotic livers, ascites, esophageal varices.
Yes.
If I see somebody who's been okay and then they start to have an increase in their weight, checking for ascites, also cardiac evaluation sometimes for right-sided heart failure. Because even
Especially
if they
for
don't
transfusion folks,
even if they don't transform into AML over time, things are going to get worse. And so just trying to keep that relationship with the patient going and talking to them about how do you feel about the way things are going and setting them up for making the best decisions for their family.
The point about, things changing over time, I think the anemia, I have a patient that's the best example. If you have somebody who's had multiple transfusion and they have a normal ferritin, they've got to be bleeding somewhere.
Right, exactly.
And esophageal varices are one of those primary culprits, and so this particular patient gets regular scopes. Because when you have a huge spleen, you end up having a big liver that then causes esophageal varices. So just like anybody with chronic liver disease, they're going to need to have that as a part of their treatment plan.
And sometimes banding, regular banding for esophageal
so
varices.
not always blaming the disease, but always looking at the other potential causes,
Okay. And then that was kind of, but this is on therapy. Any difference in what you should look for? We addressed that, I think. Anybody in the room with a question, burning question? No. Okay. How often are you checking CBCs after starting a JAK inhibitor? And what changes in counts typically trigger a dose adjustment versus continued monitoring?
It depends.
Yeah, it depends.
Yes, it does. I agree.
We have things in common, but nobody looks the same. I think depends on what cytopenias they're coming in with. I think also, we didn't really touch on it much because it's not something that comes on so often, but it is important to make sure you're doing neutropenia monitoring as well. A little bit more rare with the JAK inhibitors, but definitely something that I think should be included in the conversation, making sure we're not dropping the counts all the way across the board.
There's a question here. I'm going to jump ahead, Sarah, because it says our clinic refers patients to Moffitt Cancer Center.
Woohoo.
Because we don't offer stem cell transplants in our healthcare system in Southwest Florida, SWFL, I think that's what that means. Would it be advised that the original provider provides a JAK inhibitor as they are being referred, or is it advised to let the transplant center determine and prescribe? Very good question for both of you.
Yeah.
I didn't catch all of the question.
So if I have a patient who is transplant eligible, I'm in the community, you're my referral center for a transplant, should I start treatment or refer first?
Well, I'm biased. I do think that patients with myelofibrosis, since we saw it's such a rare disorder, our preference would be to refer them to us so that we can make treatment recommendations and see if they're eligible for a clinical trial that might have preliminary evidence that there's less toxicity and a great benefit.
That would have been my exact same answer.
Yeah, and that was the point, because some of those trials are with keeping in mind that there's a transplant arm, you know, as we get going, there are, you know, so it's, and then they can always be managed locally if they're on a JAK inhibitor, so that caught my eye, so.
The pelabresib that we touched on is one that is a perfect example. Somebody who hasn't been on JAK inhibitor therapy, that was an upfront study to be able to consider it fully.
Yeah, I think we're at time.
Yes, do we?
Wow, that went quickly. So thank you so much for being here. For those in the room
up
and all
early.
of you that are attending via Zoom, we thank you for your participation, and it's been a real pleasure. So if after this session concludes, please scan the QR code or visit peerview.com/MF26ARS to claim your credit and access the activity materials that you can use in communicating with patients, and then stay tuned for the online activity based on this event. So thank you so much.
Enjoy the rest of Congress.
Yes.
Thank you.
Okay, check your devices.